Welcome dear all for the monthly NephroTube teaching case. In this presentation I will present three cases related to lupus nephritis and infection related glomerulonephritis. At the beginning I want to mention that you can join all NephroTube social media accounts, the Facebook group, the Facebook page, the WhatsApp group, the Telegram group, and the YouTube channel. You will find the recording of this lecture and all lectures of NephroTube on YouTube on our channel NephroTube. Once you visit the channel, visit the playlist button, you will find all the lectures are classified into playlists in the two languages, English and Arabic languages. For example, here hemodialysis in English, hemodialysis in Arabic, electrolytes in English, electrolytes in Arabic, and so on. And you will find a playlist called Teaching Case of the Month. You will find all the cases, all the monthly cases, including this presentation in this playlist. Also, you can visit our website, nephrotube.com. You can find also here the social media accounts of NephroTube, all what about NephroTube online courses, my nephrology books, and the links for the videos, and you can also download the PDF of all the lectures from here. Let's start by case 1 out of 3. This is a 38 years old woman, housewife, with hypothyroidism, treated from 2 years ago, and has high blood pressure from 8 months ago. Treated without drugs. She didn't take any drug for her hypertension. Presented with 1 month of general weakness, facial and legs edema. There are no cardiorespiratory, neurologic, neither cutaneous symptoms. So this is a young age female with hypothyroidism and hypertension. She is now presenting with 1 month history of weakness, facial and leg edema. On physical examination, she appeared well with facial and legs edema. Blood pressure was high, pulse is good, respiratory rate is good. She didn't have any fever. Pulmonary sounds were diminished in both basal areas, indicating that there is effusion in the lungs. Hemoglobin was low, white cell count is good. Her creatinine was high, 1.9. Blood urea nitrogen is high, 35. Total cholesterol is 185. Serum calcium 9.5. Urine analysis showed 24-hour urinary protein of 3.1 gram per 24-hour of urine, and erythrocytes 250 RBC per high power field. So we are facing a case of glomerulonephritis, a young aged female with history of hypothyroidism and hypertension, elevated creatinine and blood urea nitrogen with proteinuria, non-nephrotic range proteinuria, and hematuria. Renal sonography show increase with normal increased the size with normal corticomedullary differentiation. Chest X-ray showed bilateral effacement of costophrenic angle due to pleural effusion. Immunological tests. All immunological tests regarding serology and virology and complement were ordered, but the results are not arrived at biopsy procedure moment. But tests for hepatitis virus were negative. But we don't have here ANA, ANCA, anti-double strand, HIV, or serum complement level till now. A renal biopsy was taken. What do you think? What is the pathological finding in this case? Is it mesangial proliferation, proliferative glomerulonephritis, tubular necrosis, or membranous nephropathy? Please answer in the chat box. What do you think? So most of the answers are going with B, and right, the correct answer is B, proliferative glomerulonephritis. It is not mesangial proliferative because you can, in mesangial proliferation, the capillary lumen will be open. And also it is not membranous nephropathy, and there is no tubules, clear tubules in the biopsy that we can say that it is tubular necrosis. So this is a proliferative glomerulonephritis, and for sure this is usually a case of proliferative glomerulonephritis due to lupus. So this is a case of lupus nephritis. For sure we cannot say it is diffuse or focal proliferative glomerulonephritis because we don't know how many of the glomeruli affected in this biopsy. You only have one glomerulus. So it is a proliferative glomerulonephritis, and the lab investigations of the cases showed later that ANA and anti-double strand were positive. So this is a case of proliferative glomerulonephritis due to lupus. With more zooming for the biopsy, we found this lesion. What this lesion is called in case of lupus nephritis with proliferation in the glomeruli? Can you answer in the chat box? What is this sign is called? Yes, as you mentioned, all of you, this is a wire loop appearance. And my question now, the presence of wire loop in the biopsy of a case of proliferative lupus nephritis is an indication of activity or chronicity of the case. Is wire loop an indicator of activity? Is an index of activity or chronicity? Yes, as all you mentioned, wire loop is an indication of activity. Regarding the immunofluorescence of the case, as you see here, immunofluorescence for IgG and IgA were positive, and immunofluorescence for C3 and C1q also were positive. So this is near what is called full house. And the final diagnosis, also immunofluorescence for IgM were positive too. So this is a full house immunofluorescence. The final diagnosis was lupus nephritis class 4A with hyaline thrombi. Class 4A, A for activity, and 4 for diffuse or focal proliferative. It is for diffuse proliferative. Why it is diffuse proliferative? Because 50% or more of the glomeruli are affected. If the affected glomeruli are less than 50%, it is called focal proliferative glomerulonephritis. And it is active due to the presence of wire loop. So these are the indices of activity and chronicity in cases of lupus nephritis. You can see here wire loop and the hyaline thrombi. Both of them are under the title of hyaline deposits, are indicators of activity. So our case is in active phase of lupus nephritis, which indicates that it can be treated aggressively with immunosuppressions. And again, that was the wire loop presented in the case indicating activity. Okay, so what do you think the specific management that should be used for induction for this case in addition to corticosteroids according to the recent KDIGO guidelines? What would you add for this case for induction of remission beside the pulse corticosteroids? We have different opinions in the chat box. MMF, cyclophosphamide, any other opinion? According to KDIGO. Okay. Most of the physicians in this case, we have rituximab, MMF. Okay. Most of the physicians in this case will choose, according to KDIGO, MMF because she is a young age female, and because we are fear of the toxic cyclophosphamide effect on the gonads and ovaries. So it's better to avoid cyclophosphamide in these cases and to prescribe MMF. So this is the approach for management of proliferative lupus nephritis according to the latest KDIGO guidelines. You will use steroids. Usually macrophenolic acid analogs are selected in young aged females to avoid the gonadotoxic effect of cyclophosphamide. And if MMF and cyclophosphamide, both of them, are contraindicated, you can use calcineurin inhibitor plus macrophenolic acid analog. The belimumab plus macrophenolic acid analogs or reduced dose cyclophosphamide is used usually in cases that are not responded to other lines. Regarding rituximab is not recommended as first line in these cases. Rituximab can be used or considered only for patients with persistent disease activity or inadequate response to initial standard care of therapy. Okay, what about maintenance therapy? Which drug you will prescribe here for maintenance beside steroids? Would you prescribe MMF for maintenance or azacitidine? Okay, as you mentioned, yes, the preferred or first choice drug is MMF. Okay, I want to mention another recent study and guidelines regarding the management of proliferative lupus nephritis away from the KDIGO guidelines. Recently, in February 2025, the Regency trial was published in New England Journal of Medicine, testing the efficacy and safety of obinutuzumab in active lupus nephritis. They compared obinutuzumab in comparison with placebo in all patients treated with MMF and steroids, both arms, the patients treated with MMF and steroids. And the final conclusion was that obinutuzumab plus the standard therapy, which is MMF plus steroids, was more effective than using the standard therapy alone, providing a complete renal response and side effects. So obinutuzumab, in addition to MMF and steroids, showed a better renal response than using MMF and steroids alone. That's why the recent EULAR guidelines 2025 recommended that in patients with systemic lupus and active nephritis, as our case, combination therapy should be administered only if, especially if poor prognostic factors are present. And I will show you in the next slide what are the poor prognostic factors that may be present that must encourage you to use combination therapy for induction of lupus nephritis patients. So in these cases, in lupus nephritis, systemic lupus with active nephritis, what the EULAR recommended. First, you can use MMF or low dose intravenous cyclophosphamide with belimumab, or MMF with calcineurin inhibitor, or MMF with obinutuzumab. So they recommended a combination and of immunotherapy, and they added obinutuzumab in the induction, and that was not mentioned in the recent KDIGO guidelines. So what are the poor prognostic factors that encourage us to use these combinations in KDIGO? In the EULAR. First, if there is reduced GFR at baseline, previous flares, nephrotic range proteinuria at baseline, hypertension at baseline, male sex, chronicity index more than 3, presence of crescents, or presence of tubular interstitial inflammation. Presence of any of these must encourage you to use these combinations that are recommended by the EULAR 2025 guidelines. Regarding our second case, a 90-year-old woman presented with a 4 weeks history of polyarthralgia, hemolytic anemia, and bilateral pleural effusion. NA was positive, anti-double strand DNA was positive, C3 was consumed, and C4 also was consumed. Anti-Smith and anti-RMB are in normal values. So we are facing a case of lupus nephritis. Serum creatinine was normal, blood urea nitrogen was normal, proteinuria subnephrotic range 1.17 gram per 24 hours. There is no hematuria or casts. There is no active sediment. With a diagnosis of systemic lupus, a renal biopsy is carried out to know renal involvement degree. So this is a case of lupus with kidney injury in the form of proteinuria, subnephrotic range proteinuria, with no hematuria or casts or active urinary sediment, and normal kidney function. This is the biopsy of the case. What do you think about the pathological finding? Is it mesangial hypercellularity, proliferative glomerulonephritis, crescentic glomerulonephritis, or membranous nephropathy? So as all of you mentioned in the chat box, this is mesangial hypercellularity. You can see the capillaries are open, but there are some areas of the mesangium where the number of the nuclei are increased. So this is a case of mesangial hypercellularity. Mesangial hypercellularity is which class of lupus nephritis? Is it class 1, class 2, class 3, 4, or 5? Which class of lupus nephritis is mesangial hypercellularity? Yes, this is a class 2. Okay, this is the immunofluorescence. As you can see, IgG is positive in the mesangial area. This is the mesangial area, and also C3 is positive in the mesangial area. So we have a class 2 lupus nephritis with normal kidney function and subnephrotic range proteinuria. What would be the next step of management? What do you think? I will ask the question in another way. Should we start immunosuppressives here targeting the kidney, or we will use immunosuppressive medications according to the extra-renal manifestations, and we will just use supportive measures to protect the kidney? So you will start supportive with immunosuppression for extra-renal manifestations, or you will start immunosuppressive targeting the kidney? What do you think? Yes, as all of you mentioned, yes, in class 1 and 2, if we have low level of proteinuria, as our case has a proteinuria of 1.17 gram per day. So immunosuppressive treatment guided by extra-renal manifestations, and we just have to start, general supportive treatment, ACE inhibitor, ARBs, maybe SGLT2 inhibitors, and so on. In these cases, we only start immunosuppression if there is nephrotic syndrome, and in these cases, usually you will find food processed effacement on electron microscopy, what is called lupus podocytopathy, and these cases you will treat as minimal change disease. Our last case, case 3. This is a 58-year-old man presented by trauma from a fall on a bicycle with a fracture of the tibia and the fibula, which was treated surgically, presenting weeks later after this surgery and this trauma, presenting weeks later infection of the surgical wound, as well as an increase in serum creatinine 1.9 mg per deciliter, with microhematuria and proteinuria of 2.3 gram per 24 hours. So this presentation of the surgical wound infection, high creatinine, microhematuria, and proteinuria is weeks later after surgical treatment. Serum complement C3 was consumed, C4 was normal, ANA, anti-double-strand DNA, ANCA were negative, HIV and liver viruses were negative. So, as you mentioned in the chat, this is maybe post-infectious glomerulonephritis. But to be more specific, which infection? Let's see the biopsy of the case. What is the pathological finding of this case? They did a biopsy, showed this light microscopy. Is it mesangial proliferation? Is it normal light microscopy? Endocapillary proliferation or membranous nephropathy? Yes, great. As you all mentioned, it is endocapillary proliferation. You can find that all the capillaries are occluded and there is infiltration by neutrophils. You can find neutrophils. I can show you some of them here. This is a neutrophil. You can find many multiple looped nuclei, cells. This is also neutrophil. So there is infiltration of neutrophils, endothelial swelling, mesangial cells, invasion of the capillary lumen and occlusion of the capillary lumen. So this is an endocapillary proliferation. This is another stain showed also endocapillary proliferation. This is the electron microscopy of the case. What do you think it shows? It shows the left one. Check the left one. What this sign is called? Yes, this is a subepithelial hump, right? And you can find here also subepithelial deposits. Okay, so this is a subepithelial hump. And this is the immunofluorescence of the case. IgA was positive, and also C3 was positive. What do you think the diagnosis of this case? What is the cause? Yes, this is a post-infection. We have a case with a low C3, C4 was normal, and we have this, again, this immunofluorescence. Yes, as all you mentioned, this is IgA staphylococcal related glomerulonephritis, and this immunofluorescence shape is called starry appearance or starry sky. You can see the deposits as stars in the sky. They give the shape of the stars in the sky, and this is an IgA dominant infection related glomerulonephritis, and the source of staphylococcal infection here was the surgical wound of the patient. Regarding IgA dominant infection related glomerulonephritis, the clinical presentation of these cases may be in the form of acute nephritis with the presence of concurrent infection as our case. You can find a source of the staphylococcal infection as in our case. The most common sources are for staphylococcal infection are endocarditis, skin as our case, osteomyelitis, maybe other source of infection. These cases may also present with new onset or exacerbation of heart failure and cutaneous vasculitis. Our case presented with acute nephritis with the presence of concurrent infection and a clear source of staphylococcal infection. Regarding diagnosis of these cases of staphylococcal associated glomerulonephritis, for sure we have to detect the staphylococcal organism by culture of the blood or the tissue, as in our case the surgical wound. There are no serological tests available to diagnose staphylococcal organism infection. As we mentioned, C3 was low and C4 was normal. C3 was low and C4 were normal, but usually in this case you can find both of them are normal. But as in our case, hypocomplementemia may present. Hypocomplementemia may present in about 30 to 50 cases of these, 30 to 50% of these cases. Some cases may have positive ANCA test. Some cases serum IgA may be high, but as we all know that we don't measure serum IgA, and for sure kidney biopsy is mandatory in these cases for diagnosis. Regarding the differential diagnosis of these cases, how to differentiate between post-streptococcal glomerulonephritis and the staphylococcal related glomerulonephritis. The staphylococcal IgA-related glomerulonephritis, as our case, occurs when the patient is still infected. While in post-streptococcal glomerulonephritis, there is usually a latent period between infection and the onset of glomerulonephritis. Also, upper respiratory tract infection that is common with post-streptococcal glomerulonephritis is not usually the cause of the staphylococcal-related glomerulonephritis. Cutaneous vasculitis, if present, it is common with staphylococcal-related infection, but not with post-streptococcal glomerulonephritis. Actually, our patient had no cutaneous vasculitis, but if it is present, it suggested more staphylococcal-related GN than post-streptococcal glomerulonephritis. And finally, the presence of IgG deposits favors the diagnosis of staphylococcal-related glomerulonephritis. The second differential diagnosis of staphylococcal-related glomerulonephritis is C3 glomerulopathy. How to differentiate between them? Low levels of C3 usually persists in C3 glomerulonephritis. Our case had low C3 level, but with time and improvement of the infection, C3 must return to normal. If the case is C3 glomerulopathy, there will be persistence of low level of C3. Electron microscopy can differentiate also between C3 and staphylococcal-related GN. Yes, both of them may reveal mesangial deposits and the capillary wall deposits. However, in staphylococcal-related GN, the hump-shaped subepithelial electron deposits are characteristic, and they are not seen with C3 glomerulopathy. Also, a third point to differentiate between C3 glomerulopathy and staphylococcal-related GN is the deposits of IgA. If there is high level of IgA deposits, that usually exclude C3 glomerulopathy, because in C3 glomerulopathy, the deposition of human immunoglobulins is usually scanty. The final, or not the final, the third differential diagnosis of staphylococcal-related GN is the IgA nephropathy, because in IgA nephropathy we will find also IgA deposits and C3 deposits in the biopsy. So how to differentiate IgA nephropathy from staphylococcal-related glomerulonephritis? First, older age and presentation is suggestive of staphylococcal GN, because IgA nephropathy is more common in second and third decade. Hypocomplementemia is more suggestive with staphylococcal, because we know that in IgA nephropathy usually the complement is normal, although some cases of IgA nephropathy may have hypocomplementemia, but this is not the common case. Also, we can differentiate between IgA nephropathy and staphylococcal-related GN based on the kidney biopsy. In light microscopy, in staphylococcal-related GN, you can find diffuse exudative glomerulonephritis, while in IgA, the biopsy is mainly only mesangial proliferation with open capillary loops. But in light microscopy, you will find the capillary loops are closed because of the diffuse exudative glomerulonephritis. In immunofluorescence, staphylococcal-related GN shows a stronger intensity staining for C3 than IgA, while in IgA nephropathy the opposite happens. Electron microscopy, in staphylococcal-related GN you will find subepithelial humps, but in IgA nephropathy you will not find them. Also, 1 minute please. Also, IgA vasculitis, because it resembles IgA nephropathy in the pathology, may be a differential diagnosis for staphylococcal-related infection. And to differentiate IgA vasculitis from staphylococcal-related infection, you can use the same criteria that we use to differentiate IgA nephropathy from staphylococcal-related glomerulonephritis. ANCA-associated vasculitis may be also a differential diagnosis of these cases, especially if the staphylococcal infection came with ANCA positive and vasculitis manifestation, because we mentioned that staphylococcal-related glomerulonephritis, some of cases may have positive ANCA and some of cases may have cutaneous vasculitis. So how to differentiate staphylococcal-related glomerulonephritis from ANCA-associated vasculitis? In ANCA-associated vasculitis, usually you can see in the biopsy fibrinoid necrosis in the vessel wall. You will not find this in staphylococcal-related glomerulonephritis. Also, in ANCA vasculitis, if there are usually there are no deposits. It is called pussy-immune glomerulonephritis. So in ANCA, you will not find deposits. And if you found deposits, the deposits will be IgG and rarely to be IgA. So that was our last case. I hope that you liked our 3 cases about lupus nephritis, to highlight how to manage lupus nephritis and to highlight the recently recommended obinutuzumab in the EULAR guidelines. I recommend for you to read this EULAR and to highlight also the staphylococcal related glomerulonephritis, which is always a missed entity, and how to differentiate it from other pathologies. Thank you for your attendance and see you next month, inshallah.